Ladies and gentlemen, it's my pleasure to present this talk on cardiac imaging to guide VT ablation in this new approaches and technology session of ISCAT 2020. These are my disclosures. So when we think about VT ablation, we think about substrate map and voltage map. However, there are quite a lot of limitations, such as activation wavefront, and it has been very well shown by Dr. Chung. This is particularly true in the border zone, and in this case, as you can see in this example we published, the downscale is pretty preserved, but if you change activation wavefront, the border zone may change quite a lot in terms of voltage. There are also some things that has been very well known for decades, is a bipolar orientation compared to the activation wavefront. In this case, if you are parallel to the grid, to the HD grid, the signal is pretty well seen. Whereas if you record the signals in a bipolar perpendicular, in this case, you can miss the signals. There are much more different other parameters, such as FAT, contact, electrode size and interspace, fiber orientation. So substrate can be identified only by voltage map, and there are a lot of research on different strategy for substrate mapping. So we propose there a change in paradigm and just looking at imaging, the information of imaging to identify the substrate. And plus the imaging does not only play a role to target the substrate, to identify the substrate, but also before ablation, of course, to guide ablation, and this is my talk today, and after ablation. So when you think about imaging for VT ablation, you have mainly two tools, CT scan and MRI, but you could have much more, such as ICE, MIBG, PET scan, or whatever kind of imaging techniques. I will mainly talk about CT scan because it's the spatial resolution is much better, it's easier to get, especially in patients with ICDs. And whatever is a company, the sequence are the same. But there are publications with both technology, CT scan or MRI. So we developed a platform, the music platform, in which you can integrate and incorporate all kinds of imaging technology, CT scan, MRI, even ECG imaging or rotational angiography. And then you can treat your images and then import them in your 3D system, Carto, Rhythmia, or even Insight. And we showed it's a retrospective with all the limitation of the retrospective study, but when you use real-time imaging, then the outcome seems better. But once again, this will be, we will need to prove that prospectively. So basically, the way it works is if you do a EP map, the voltage standard voltage map, this is an inferior MI here, you see that it can look pretty heterogeneous if you just look at voltage. Looking at wall thickness, and this is what we are looking at in an ischemic cardiomyopathy patient, the thickness of the myocardium, you could identify some thickness heterogeneity seen to thick mismatch, which has been proved to be pro-arrhythmogenic and substrate for reentry. And we identify with an algorithm the potential isthmuses, and then the goal is to cut this path within the scar. So basically, we are merging CT scan once it has been treated by the music software, and we are merging these images in 3D mapping system. Then we go for CT isthmus ablation directly without doing substrate map. And then we are testing induction. If it's non-inducible, we stop there. If it's still inducible, we go for VT mapping and ablation. So here is the case of a patient, and I will explain you more in details with this patient. So basically, you can have two kinds of information. The wall thickness part, the dark red is 1 millimeter to 5 millimeter, which is the light yellow there. And this map is performed with and the wall thickness is defined from the arterial time CT scan. But we also look at the venous time of CT scan to get lead enhancement, and it works pretty much like lead enhancement on MRI. It's CT scan, but the idea is globally the same. And as you can see in this case, you can have much other information. It's complementary information. So it helps to get a comprehensive substrate localization, a pre-procedural strategy, and we hope to be more efficient and have a faster procedure. And basically, the way it works is once we have identified the substrate and the potential isthmus, here the radiologist draw on PowerPoint the dots or the strategy, propose me a strategy, and we discuss that. I must say it's sometimes a bit frustrating that the radiologist knows before even you have even touched the patient what to do, and this is what I have done in this patient actually. So it looks finally less nice than the radiologist map here, but we basically do the same kind of ablation to cut all this potential isthmi there. And in this case, we had 95 minutes procedure. The patient was non-inducible at the end. Unfortunately, he did well for a year, but 1 year after, he came back with new VT. This is a 320 cycle length VT, 320 millisecond cycle length VT, and he had another one much faster, which looks a little bit, as you can see, polymorphic at the beginning. So we had two kinds of VT, and we don't have 12 lead of this VT. So we went back and we started with a substrate map. This is the inferior wall there. This is where we ablated the isthmus, and this was not capturable. So what we have done during the initial procedure 1 year ago was still effective and was still done. This is a wall thickness mark. But looking at the septal wall, we may have missed something. And as you can see, there was a little bit of thinning there in the septum. So once again, the definition is less than 5 millimeter. If the thickness is more than 5 millimeter, and it's pretty hard to be less than 5 millimeter in the septum, you will not see it. And when we look at the late contrast map, and we did not do that earlier, we saw that we were in a scar there. The tissue was not so thin; it was more than 5 millimeter in this area, but still there was some scar. And we induced the VT, and actually we had two VT, one faster than the other, but with morphology very similar in this case. We could not do activation mapping because after 30 seconds, we had to stop the VT because it was too fast. So we had some mid-diastolic part at the beginning because the Orion was placed just when I think it was, based on pace map, and we were mid-diastolic, but we could not map all because we had to stop. And then we finished to try to reconstruct the path of the VT by pace mapping. And you can see with the morphology, which is pretty good with a short SQRS, so showing probably the exit towards this area. So we anticipate, and we deducted that from that the circuit was going this way. So what we have done is actually two kind of lines from the mitral annulus to this septal scar, and then to this septal thinnest part to the more inferior thin part. All of that was scar, but some area was similar to the other, and we tried to connect that to render the patient non-inducible. So our preliminary results, we have 25 patients performed with this strategy so far with a follow-up of more than 12 months. 5 were still inducible at the end of the channel ablation with fast VT in 4, and 1 with a VT of less than 200 milliseconds had an isthmus not blocked. So for this one, we did block the isthmus. So we went back on the isthmus which was not blocked, and we ablated more to get rid of the isthmus. And for the other, we did perform the ablation based on pace map. It was mainly in the border zone, so not looking like heterogeneity of wall thickness, but more patchy area on the border zone of the scar for the fast VT. Those patients, we managed to get non-inducibility in this patient. The mean procedure time was 110 minutes, and compared to historical cohorts was half reduction in terms of procedure duration. And at 1 year, we had 2 recurrences. One had a VT from a previously ablated area, and we had to re-ablate again, and the other is the case I've just shown you. We are not using that only in ischemic cardiomyopathy patient, but also in a patient with non-ischemic cardiomyopathy, and especially the late sequences, the late enhancement, because in this case, most of the time the wall is not thin enough, but you still can see the scar with this venous time CT scan, and it helps a lot to identify substrate and to target this kind of substrate. As you can see this example, the arterial CT scan is mainly done to measure thickness of the wall, to very well define the myocardium, and the late time with the contrast there for the scar. So to conclude, ladies and gentlemen, voltage map gives you a rough idea of the substrate. Yes, cardiac imaging could, and we hope to show that should guide VT ablation, but it remains to be demonstrated. But cardiac imaging has also a role before ablation to rule out contraindication, plan your strategy for channel ablation, but not only bipolar ablation in case of intramural septal scar or epicardial access, and also during ablation to spare time and avoid complication. Thank you very much.